I'm the doctor, so I'm going to do it. Don't get it. Wait for my Dad asked somebody to record. There we go.
And then same when we go to like the challenges and stuff, I'll just say, Devin, please feel free to add anything like that if you need to.
Greetings, everybody. Stand by for just a few seconds here. We're preparing to give the VA scan presentation, the pharmacy grand rounds. So just bear with us while we allow a few more participants to join, and we'll get started. Thank you for attending. Greetings, everybody, and welcome to today's VA Scan Echo presentation, Pharmacy Grand Round Series. We have Lindsay Cowan and Ms. Devin Mills here today to teach you the pharmacy presentation. A couple housekeeping notes before we begin. Please make sure your microphones and telephones are on mute. The reason that we mute our microphones and telephones is so that we do not disturb the speakers and do not disturb other participants. Also, in order to receive credit, you must follow the instructions that are included on the slideshow. There are special instructions for pharmacists that are. Pharmacists will have to follow those instructions in order to get ACPE credits. If you are not a pharmacist, this includes nurses, NPs, PAs, doctors, etc. Email myself. That's Christopher.Begger, B-E-G-G-E-R, @va.gov by close of business today. Again, pharmacists, follow the link. Everybody else, email me. Again, make sure your telephones and microphones are muted. And here's our presenters.
All right, go ahead and get started. My name is Lindsay Cowan. I am a research and specialist here at the Denver VA. And with me is Devin Mills, who is a neurology nurse practitioner. Devin and I have worked together over about the past year and a half on starting levodopa carbidopa enteral suspension, also known as Duopa, in some of our more advanced Parkinson's disease patients. And we want to take the time to share what we've learned and how to do that in a VA environment. We do not have any financial disclosures, and because carbidopa-levodopa enteral suspension is referred to as Duopa colloquially in the VA, we're just going to go ahead and use that term. For this presentation, we want you to become familiar with Duopa, develop confidence in identifying benefits of initiating this drug in patients, be able to identify patients with Parkinson's disease who are potential candidates for Duopa, learn how to navigate the process of ordering Duopa in the VA system, which is not always an easy process, and also appreciate the complexities of Duopa treatment and the potential challenges that might arise. So Devin's going to start out with a brief review of Parkinson's disease.
Okay, and just please do know that this is just a very brief overview of Parkinson's disease. Parkinson's disease is characterized by degeneration of dopamine neurons in the substantia nigra, pars compacta, with resultant depletion of dopamine, leading to those core motor features of the disease. The classic motor symptoms of Parkinson's disease include resting tremor, increased tone, bradykinesia, which is more slowness of movement, and gait and balance problems that progress over time. There's also the non-motor symptoms associated with Parkinson's disease, such as sleep disturbances, urinary dysfunction, constipation, swallowing problems, mood disorders, and cognitive deficits are also very common. You'll hear patients describe quote-unquote on and off times. On-time references when their Parkinson's disease is well controlled and patients feel their medications work. The off times typically reference they can feel their medication wearing off, and they will have returning symptoms such as slowness, stiffness, tremor. And then there's also this on-off phenomena, which occurs when patients have unpredictable sudden changes with dyskinesias and immobility problems. Sometimes you'll also hear them say that they're frozen. Freezing episodes are sudden, brief periods of immobility where patients may feel that their feet are literally stuck to the floor. And this happens most frequently when going through doorways, initiating walking, or turning around in tight spaces. So just jumping real quick to the benefits of Duopa. They include potential reduction of dyskinesias by 30%, reduction of off time by 55%, eliminate the need to continuously take oral medications throughout the day. It's an overall low risk of severe complications. And we also see improvement in non-motor symptoms such as sleep fatigue, urinary, sexual complaints, and even perhaps mood. The risks tend to be very similar to what you see with your PO, carbidopa-levodopa. However, with the addition, the most common adverse events were related to the surgical procedure or the device, and that included tube displacement, the need for additional procedures to repair or replace the tube. These adverse events primarily occurred within the first 2 weeks, and they weren't associated with any residual deficit. Furthermore, proportionally fewer adverse events related to the device occurred that have been reported in the literature, which might show a reduced adverse events with increased experience in performing the actual procedure, the placement of the GJ2.
Okay, I'm going to briefly review the pharmacotherapy for Parkinson's disease. I'm going to talk about motor symptoms here and the drugs used to treat those. Most non-motor symptoms like mental illness, sleep disorders, and autonomic dysfunction are treated that are really not specific to Parkinson's. There may be the exceptions that new drugs come of answering for Parkinson's. So the first and foremost, and probably the most important drug used in Parkinson's is carbidopa-levodopa. Levodopa crosses the blood-brain barrier and is converted to dopamine in the brain, where it reverses the depletion that's found in Parkinson's disease. Carbidopa is in a class of medications called decarboxylase inhibitors. And what this does is it prevents the breakdown of levodopa before it reaches the brain for a lower dose of levodopa, which causes less nausea and vomiting. There are 5 dopamine receptor agonists. These improve motor symptoms by directly acting on the dopamine D2 receptors. As you can see, they come in a variety of dosage forms. You have retigatine, which is a patch, apomorphine, which is a rescue subcutaneous injection. It's a high-potency medication, and it's for the off periods or unpredictable on-off periods. Catechol-O-methyltransferase, better known as COMT inhibitors, entacapone and tolcapone, they work by preventing the metabolism of levodopa in the periphery, which increases the amount of levodopa reaching the brain. These are used with carbidopa and levodopa, and they improve off time. Next is the monoamine oxidase type B, MAOB inhibitors. These medications work in the brain to prolong the action of dopamine. These are really useful in early mild Parkinson's disease to prevent the need for levodopa, but they can be used in conjunction with other agents as the disease progresses. Next, we have our anticholinergic agents, and these drugs are used mainly for tremor, and they restore the balance between acetylcholine and dopamine in the brain. Amantadine is kind of unique. It's an antiviral agent and also an NMDA receptor antagonist, and it acts as an anticholinergic in this case. And then lastly, we have combination agents like the carbidopa, levodopa, and entacapone combination. So moving on to Duopa. So Duopa is a carbidopa-levodopa suspension that is infused directly into the small intestine via an external pump that the patient wears. 16 hours of continuous carbidopa-levodopa delivery. It was FDA approved in 2015 as an orphan drug. It's manufactured by AbbVie and is only dispensed at one specialty pharmacy in the whole country, and that's Accredo. It's currently approved in 41 countries and marketed outside the United States as Duodopa. You'll hear it referred to as an intestinal gel in other countries and in many of the studies. But looking at the drug, it looks like a white milky substance, and it looks much more like a suspension, and that's what the FDA has them refer to it as here. So it's a suspension. It is FDA indicated to improve motor fluctuations in advanced Parkinson's disease. So motor fluctuations are really those on-off periods that occur in the majority of Parkinson's patients. And they think these result from the pulsatile stimulation of dopamine receptors. Over time, the therapeutic window becomes narrower as Parkinson's disease progresses. So keep in mind that Duopa will not really address dopamine-resistant symptoms like freezing of gait and talking and thinking problems. It's also important to note that it is helpful in treating disease symptoms, but has not been shown to delay disease progression, and it is not a cure. So a little more specifics about it. It is delivered directly into the jejunum via a tube that has been placed there using that PEG-J procedure. It bypasses the stomach, which is a good thing because levodopa is primarily absorbed in the small intestine, and it provides less variable levodopa plasma levels, which really helps with those on-off symptoms. Another reason it's good that it bypasses the stomach is that it avoids the effects of delayed gastric emptying, which is an issue with a lot of Parkinson's patients. So if you can look at the slide that shows, can you see what a patient on this medication looks like? You can see how the pump is connected and how the cartridge then fits into the pump. It uses a CAD Legacy 1400 infusion pump, and it is programmed by the provider to deliver individualized patient doses. So this next slide here shows a patient, an actual patient that is on this medication and kind of what it looks like. This fellow might have had his tube placed fairly recently since he has a lot of gauze around it. But you can kind of see what it's like there with the tubes and everything. Okay, so a little bit more about Duopa. It comes in single-use cassettes that contain 100 ml of carbidopa-levodopa suspension. The package labeling recommends a max of 2,000 milligrams of Duopa per day, which is one cartridge. But some patients require 2 cartridges per day, and that is an off-label use of this medication. It needs to be kept in the refrigerator until needed. It comes with a carrying case if you, we'll discuss Duo Connect in a few minutes, but it comes with a carrying case. There are also vests and other pump wear that can be purchased. Vests, and Devin will talk a little bit more about that in a little bit. It's important that patients are still prescribed oral carbidopa-levodopa medications, not to use while they're on it, but to be used in case they're disconnected from the pump for more than 2 hours, because inevitably this will happen, and it's good just to have those medications on hand. And they also might need a nighttime dose of oral meds because you're only using the drug for 16 waking hours during the day. So if you have patients that have significant symptoms at night, you may need to supplement it with an oral dose. So now we have an assessment question. Choose the correct answer. Duopa is A, cognitive symptoms associated with advanced Parkinson's disease. B, a relatively new drug for advanced Parkinson's that slows the progress of the disease. C, a novel way of administering carbidopa-levodopa that results in less off time. And D, a new drug that works to overcome dopamine-resistant Parkinson's symptoms like freezing of gait and talking. So the answer is going to be C. So first of all, it's indicated for motor symptoms, not cognitive symptoms. It does not slow the progress of the disease, and it does not work for dopamine-resistant symptoms. So this is a slide. This slide just shows what a day in the life of a Duopa patient's like. There's a lot of steps. They have to take, first of all, in the morning, take the Duopa cassette out of the fridge, leave it at room temperature for 20 minutes so that it warms up a bit. You're going to connect the cassette to the pump, flush your PEG-J tube with 20 mLs of tap water, then connect the pump to the PEG-J tube. You're going to start your pump and you'll receive your morning dose. And then right after that, the continuous dose starts and continues for 16 hours. After that 16 hours, you're going to disconnect the pump, flush it again, and remove and dispose of the cassette. So for a lot of these patients, they're already in advanced stages of Parkinson's, and they might need caretakers to help with these tasks. It's always kind of important to have a family member or somebody else who's familiar with this and can help with these steps. So now I'm going to go through a few things that are in the package insert. Contraindications. So hypersensitivity obviously is a big one. You cannot use non-selective MAOIs, like phenelzine, trancypramine, within 2 weeks due to hypotension concerns. Narrow angle glaucoma is a contraindication. However, wide angle glaucoma isn't, and patients should just be treated cautiously because this drug can increase intraocular pressure. Anybody who has a history of melanoma or anything that's suspicious for it should not be treated with Duopa. And also there are a great number of contraindications to the PEG-J procedure itself. I'm not going to read through those, but the patient obviously has to be a candidate for even getting the tube to begin with. Adverse effects. This is a good little list here. The biggest one, like Devin pointed out, is going to be the complications with your device insertion. That's just part of this. Nausea is the next biggie, I'd say, with this. Carbidopa-levodopa does this, and that's one thing to really watch out for. Depression, once again, we'll talk a little bit more about that, but some of these other ones are just related to carbidopa-levodopa alone. So here's a few other considerations, and once again, many of these are related to just using carbidopa-levodopa in general and really aren't that specific to Duopa, so I'm going to kind of fly these in pretty quickly. Dyskinesias. This is maybe probably one of the more important ones here because given the patient's Duopa can cause or exacerbate these, and you might need to decrease the dose. So this is one thing to really watch for. Orthostatic hypotension, especially after starting or increasing a dose. Just monitor for that. It can cause prolonged constipation, nausea, vomiting, fever, melanotic stool. I think those would be, pretty rare, but it's something to be aware of. Daytime somnolence. So there's some patients who've had this medication who they report falling asleep while they're doing something, maybe even driving. A lot of them have reported this is like a sleep attack where they were perfectly alert and awake right before it happened. So if this becomes an issue, just please stop the drug. Hallucinations, psychosis, and confusion. Patients are just at a higher risk of that. Hallucinations can, of course, start after therapy has started. And once again, these all may be responsive to dose reduction. And if patients have major psychotic disorder, it's not really a contraindication, but it's something, to consider before starting on these medications. Urges, intense urges such as increased gambling urges, sexual urges, uncontrolled spending, binge or compulsive eating, or other urges may become more common with these patients. And, because patients really don't think of these behaviors as strange or different, it's important to ask the patients or their caregivers even better about this. Depression. Depression is fairly common in Parkinson's patients to begin with, but apparently, levodopa can increase that risk. So just monitor for that. Add antidepressants if need be, or consider reducing the dose or discontinuing if it's really a problem. There's a risk of myocardial infarction and arrhythmias. Elevated BUN and CPK, and this is independent of GFR. So your GFR might just be fine, but you might notice that patients have increased BUN or CPK, and this is something to consider. This is one of the reasons why that could happen. And like I already mentioned before, increased intraocular pressure. So monitor your patients that have glaucoma that you are using this in. Drug interactions. Your selective MAOB inhibitors, selegiline or sagiline, they may cause orthostatic hypotension, but Devin and I discussed this, and this may or may not be clinically significant. There might be a small effect or really no effect on that, so just use your best judgment on that. It's not really a contraindication or anything. Antihypertensive drugs may need to be adjusted for if the patient's having some postural hypotension. And there's a couple meds that can reduce the effectiveness of Duopa that you want to consider. The first is the D2 receptor antagonists, and these are mostly your psych meds. These are like risperidone, ziprasidone, paliperidone, droperidol, olanzapine, and others. So just be aware of patients who might be on those medications, and it makes sense. You don't want to block any dopamine, areas there in the brain. Isoniazid and iron salts is another one that a lot of folks aren't aware of. Your patients taking oral iron. And high protein diets. So protein affects the transport of the medication from the intestines to the bloodstream. And it's just important for the patient to be consistent in their protein intake. All right, dosing Duopa can be a little tricky. I'm going to try to go through it, try to simplify it as much as possible. So there's 3 doses that will need to be calculated, and they'll be programmed into the pump by the provider. So you have your morning dose, your continuous dose over 16 hours, and then extra doses. And the easiest way to start that is by converting the patient's other dosage forms of carbidopa, levodopa, like your SR or your CR and your ER forms, over to the IR form. And have them take that IR form for a little while, and then it's easier to do the math. But I know Devin doesn't necessarily do that. She just kind of converts what they're on and then starts them on that without doing that. So it's probably a judgment call on the provider's part once again. And do not stop concomitant Parkinson's medications. Patients can take all the other ones, not carbidopa, levodopa, but all other ones while they're on this med. So to calculate the morning dose, I'm going to kind of go through this pretty quick, but if you need to reference them, they are in the package insert. So first thing you're going to do is determine the total amount of levodopa in milligrams in that first dose of that carbidopa, levodopa IR that they take in the morning on the previous day. So look at their first dose of Cinemet in the morning. And then you're going to convert those milligrams to mLs by multiplying the dose by 0.8 and dividing it by 20 mg per ml. And because you have to prime a tube, you're going to add 3 mLs to that dose, and that's your total morning dose. This will be 10 to 30 minutes, and of course, depending on the size of the dose, and once again, it's provider's discretion on how many minutes they want to set that to, and they would program that into the pump. And that continuous dose would start right after that. So for the continuous dose, you want to go back again and look at the total amount that the patient got in levodopa milligrams the day before, during 16 hours that most people are awake. Do not include any levodopa that was taken during nighttime or normal sleeping hours. So then you want to subtract from that first oral levodopa dose taken by them in the morning. Divide the result by 20 mg per ml, and that's your dose in mLs. And you're going to administer that over 16 hours, so you just divide it by 16 to get your hourly infusion rate. And that is your continuous dose. So, like a PCA or pain pump, this pump has an option for a PRN or on-demand dose. And this is for patients who are having acute off symptoms and they're not really being controlled well by the morning or continuous doses. So the suggested starting extra dose is 1 ml, which is 20 milligrams of levodopa. It's titrated up in about 2 ml increments. These off symptoms these patients may be having are, things like bradykinesia, resting tremor, muscle rigidity. Those are the things you kind of want to have this dose available for. And then, of course, if you administer frequent extra doses, it may cause or worsen dyskinesias. There's some patients who might like that dopamine high, so you got to watch out for that. But it's nice to have it when they need it, for sure. And then for titrating the dose, I'm going to have Devin comment on what a titration visit looks like typically. There's going to be some monitoring involved.
Right, yeah. So I typically will bring the patient in early in the morning and have them be in their off state. However, depending on how advanced your patients are with their Parkinson's disease, they may not be able to come in off, and that's okay. Have them take their morning meds, and then when they come into clinic, just start them on their continuous dose. You're going to perform your physical exam, should get a set of vitals. I just educate them a little bit more on expectations, and then we go ahead and start the dose. My patients have tolerated this incredibly well. I typically will monitor them for approximately an hour. If they're stable, I'll have them go down to the canteen, grab some breakfast, come back up, reassess their physical exam and their vital signs, and ultimately ask them how they feel. As long as their vital signs are stable, there's no adverse that are noted, they can certainly go home. But the most important thing to do is complete a diary, which they need to be very specific about, their on times, their off times, any dyskinesias they're having. And this is really important data to have, so when they come back to you in clinic, you can assess what adjustments may need to be made. So that for that first week, I'll typically start the titration on a Monday, bring them back on a Wednesday, and then again on a Friday. Typically, this will always be done on an outpatient visit. However, there are cases which may require an inpatient stay, but that's a whole other lecture.
So for for other titrations, like after their titration visit, so if a patient's having a lot of off periods, you can increase the dose on it, or even increase the extra dose as well. And once again, you consider decreasing the dose for any dyskinesias or other adverse drug events. So we have one more assessment question here. Which statement is true regarding Duopa dosing? A, patients should first be converted to the IR forms of carbidopa-levodopa before starting Duopa. All concomitant PD meds should be stopped once Duopa is started. The morning dose is administered over 1 hour, then the continuous dose is started. Or too many extra doses may result in worsening motor symptoms. So correct answer is A. Everyone should be on the IR forms first. Typically, that's what this recommended in the package insert. So you don't want to stop your concomitant PD meds. Morning dose is administered between 10 to 30 minutes. And too many extra doses can result in worsening dyskinesias. All right, so
I'll try not to drag out the literature review too much. So there's numerous quality studies out there, but for purposes of today's presentation, these 4 were chosen. So the pivotal study was the Olanow et al. Study, which was a 12-week randomized, double-blind, double-dummy double titration of carbidopa-levodopa intestinal gel versus optimized oral IR carbidopa-levodopa. It was a 3-phase study. It featured about 26 centers in the US, New Zealand, Germany, and but 66 wound up completing the trial. So both groups were titrated to optimal effect. The inclusion criteria, you can see this on the slide too, but basically the age range was 39 to 83. They had to have a clear responsiveness to levodopa, more than 3 hours of off time, recognizable on and off states. And the exclusion criteria included previous neurosurgery for Parkinson's disease, Alzheimer's disease, acute psychotic disorders, sleep attacks, acute stroke within 6 months. The key points on the pivotal study design were that everyone was converted to IR carbidopa-levodopa. Everyone also had a PEG-J2 placed. The double-blind therapies were started and titrated to response through week 4. And then after week 4, patients remained on fixed doses of both study drugs, as well as any complementary Parkinson's disease meds. So you can see how the double dummy design works here. Half the patients were receiving Duopa with oral placebo for the IR carbidopa-levodopa, and the other half were receiving placebo for Duopa with oral IR carbidopa-levodopa. So primary endpoint was a change from baseline to final visit in motor off time. The secondary endpoint was motor on time without troublesome dyskinesias. So the result, 90% relative reduction in mean daily off time with Duopa. So that's 4 hours compared with the oral carbidopa-levodopa, 2.1 hours. And 86% relative increase in the mean daily on time without troublesome dyskinesias with Duopa. So 4 hours compared with about 2.2 hours with oral carbidopa-levodopa. So adverse effects, again, it's going to be that insertion device. So adverse events were reported in 94.5% of Duopa patients and 100% of the oral form of carbidopa-levodopa. But again, that includes all patients who receive, or all patients did receive the PEG-J tube. So serious adverse events occurred in 13.5% of Duopa patients and 20.6% of oral carbidopa-levodopa patients, respectively. And that included things like confusional states, pneumonia, and here's just more adverse study reactions continued. So the other study was a fairly large study by Fernandez et al. It was designed to provide needed longer-term safety and efficacy results with clinical applicability to an international patient population with advanced Parkinson's disease. The study also investigated the initiation and maintenance of Duopa as a monotherapy, replacing any type of complementary Parkinson's disease therapy. Primary endpoint was safety, and secondary endpoints were diary assessed off time and on time, with or without troublesome dyskinesias. The UPDRS, that's the Unified Parkinson's Disease Rating Scale, and the HRQOL, which is the Health-Related Quality of Life Outcomes, was used. So most adverse reactions were mild to moderate, again with the most complication being the tube insertion. Mean off time improved by 4.4 hours, and on time without troublesome dyskinesias improved by 4.8 hours. So both the UPDRS and the quality of life scale, both of those outcomes were improved. And the authors concluded that Duopa was generally well tolerated and demonstrated clinically significant improvements in motor functions, daily activities, and quality of life measures sustained over 54 weeks. The Antonini sorry if I'm butchering that name, Antonini et al. Was a prospective study over 12 months in 9 patients on Duopa, but only 7 actually completed the period. Their results demonstrated that a satisfactory therapeutic window can be achieved and maintained for several months in advanced Parkinson's disease. Duopa improved motor conditions and reduced disabling dyskinesias, resulting in significant benefit in quality of life measures. The Chang et al. Study looked at efficacy and adverse profile of Duopa. I'm not going to go into too much details here since the results are very similar to the other studies we've talked about. But the main point out that the peripheral neuropathy caused by vitamin B12 and B6 deficiency was common in adverse event in the study. From a clinical perspective, you're monitoring these patients similar to how you would on PO carbidopa levodopa. You're making sure that you're not causing a peripheral neuropathy. You're checking labs routinely and adding PO therapy of vitamin B12 or folic acid as needed. So our patient selection, how we define advanced Parkinson's disease is certainly subjective, but I like this slide because it can help providers. It's kind of a guide to help providers. But again, at least I like to look at kind of what their overall quality of life and day-to-day life looks like. Are they having repeated falls at home despite optimal treatment due to these motor fluctuations or dyskinesias? Are they having a decreased level of functioning because their off time is more than 2 hours? Are they having weight loss, recurring upper respiratory infections due to dysphagia? Are they tolerating a high pill burden? Or are they just so sick of taking pills every 1.5 hours? Are they having troublesome non-motor symptoms despite them being optimized on their therapy? And then, of course, you're looking at their sleep quality. And what about their loved ones? What concerns do they have? So the inclusion criteria for Duopa is an excellent response to levodopa, severe motor fluctuations, unpredictable offs, 3 off times 3 hours of off time during the waking portion of the day, and the ability to manage the pump. So ability to manage the pump specifically is actually one thing that's really important is that they're able to flush their tube. If they do not flush adequately or properly, that medication dries up like a Jolly Rancher, I would say. It's very sticky, and it basically will just solidify, which would require potentially having that whole tube replaced. So having the dexterity to flush and the strength to flush is really important. And also just their caregivers, if they need a caregiver, are they willing to provide the help, and are they able to provide the help? So exclusion criteria, I think that, this was actually already discussed quite a bit by Lindsay. So I'm going to have her move on to ordering Duopa at the VA. Oh, actually, I lied. That's my part. So here, I just want you to know that the criteria for use is on the PBM SharePoint site. So clinically speaking, when patients come in, and if you're able to identify a patient, the first thing I have them do, if you're thinking about them being a potential candidate, is having them call this phone number that's on the slide, Duo for You. This will allow them to speak with somebody who's already on therapy, and they can discuss the pros, the cons, and they'll help answer questions. Whenever you bring up, placing a tube with a patient, they look at you like you're absolutely crazy, and there's no way that they would consider that. So this does tend to be a very long process of kind of having that seed planted and then just keep reassessing on your subsequent office visits with them. I think the turnaround typically that I've had is anywhere from 6, maybe even 9 months to a year until they kind of come around and are willing to inquire more about this type of therapy. So that's the first thing I do. And if they are interested, that's when I go ahead and submit the PADR to pharmacy, notify your specialty pharmacists. Once the PADR is approved, I place a return to clinic order in the fairly near future to set up an appointment, and this appointment's mainly for teaching. You're going to obtain consents and complete the other paperwork that's involved. I also like to submit a social work consult to review advanced directives. So the recommendation is that this tube is exclusively for Duopa therapy. If in their advanced directives they request that, yes, they want additional tubes for feeding, a conversation needs to happen that if they do need an additional tube for feeding, that placement of another tube, basically having another stoma placed, is going to actually help minimize complications versus having the dual Duopa therapy and feeding going into the same tube. So the other thing we want to do is submit a consult to general surgery versus IR. And this is it's a very specific tube with connectors that admittedly very highly intelligent surgeons will have difficulty with.
I have it on the next slide.
Do you?
Yeah.
Okay. So we highly recommend having an AbbVie surgical nurse present to review the tube, help answer questions during the placement. Initially, we were actually using a different tube. Here at the Denver VA, we're using a Cook tube and having it placed through IR, not general surgery. But again, the tube selection is a whole other lecture.
Okay, so now for the VA process of ordering this medication. It is a very expensive specialty medication. You can see in the picture there kind of what the tubes look like. Those are the ones from AbbVie. This whole process is very interdisciplinary. There's many moving parts that all need to come together for this to work. Some facilities have a specialty pharmacist like myself. Others might have a neurology pharmacist, and many other sites out there I know don't have any pharmacists at all. So there'll be somebody in the pharmacy who will kind of have to take over this whole process a little bit wherever you're at. So you're going to need to figure out how to order the drug, the pump, the syringes, batteries, the AbbVie PEG-J tube, and there's a kit. There's like a surgical kit that has some items in it to help with the tube placement and like an end cap, an adapter, and things like that. The Duo Connect program is free. It has no cost. It's a 24/7 hotline support for patient questions. It can be used to schedule mentor calls, either patient to patient or caregiver to caregiver. It provides access and assistance in the ordering of carrying cases. They'll schedule at-home nursing visits, up to 4 visits. Answer provider questions during pump programming or adjustments, answer provider or pharmacy questions during and after enrollment. So they are a good resource and they are there for you. So starting the ordering process here, the first thing obviously, the provider should review the criteria for use, which is on the SharePoint site. PADR needs to be approved. And then you need to go to the PBM SharePoint site and have the provider and patient fill out a prescription form, and I'll show you this in the next couple of slides. Return that to whatever pharmacy or whatever pharmacist will be handling this. And then the pharmacist will then fax that to Duo Connect. Duo Connect was going to enroll that patient and forward the RX onto Accredo, who they're the ones that fill it. Accredo will contact the pharmacy procurement for a purchase order, and then of course it's delivered directly to the patient. Timing is kind of an important thing here. So when a patient is scheduled to get their first titration visit, you need to make sure all these items are mailed to the patient, and they need to have them before the titration visit. We have our patients bring the medication in with them for that visit. And also one other thing I wanted to point out, the length of time between the tube placement and the start of Duopa, like the titration visit, it really varies. Like in the studies, they started Duopa right after they placed the tube. We do about 2 to 3 weeks here between the tube placement and starting Duopa, just to give the patient a little time to get used to their tube and make sure there aren't any issues with that. And I think the one step at a time thing works for a lot of these patients. So, and also it needs to go to contracting because it is expensive medicine. So that does take a couple days to keep that in mind. All right, so this is on the PBM website. So over on the left, you see special handling drugs, and you're going to go to the next set of pages. You go choose Duopa, And from there, there's 3 different items there. There is the start form and prescription for the VA, and that's with DuoConnect, and that's the one we use because we use DuoConnect. We think it's a helpful service. If you don't want to use DuoConnect, there's a separate prescription form there. And then there's a document called the Duopa VA ordering information, and that has a lot of information that I'm be giving you, but also some more. So it just kind of walks you through it a little bit. So here's an example of what the prescription form looks like. So the patient will have to sign it, so will the provider. You're going to have kind of your doses figured out at that point. And this just might be an estimate because you haven't started it yet, and you're going to have to change those. But they're going to want to at least have an idea of what you're going to do. So ordering the pump, there's 2 options here. The option that's mentioned in the document about ordering information for the VA is a package deal from Accredo where you lease the pump from them, and along with that you get the syringes for flushing, the adapters, and AA batteries. However, we have chosen to purchase the pump directly from AbbVie. It's a lot cheaper. We get to keep that pump for future patients then. However, you then are on your own for ordering the adapters and syringes. And we go through prosthetics to purchase the pump. Right now, nobody provides the batteries here at the VA. At this VA, patients have to supply their own. But from what I've heard, that's not necessarily the case at every VA. So this whole process might be a little bit different everywhere you go. So some of the other items here, we have the PEG tube, the J tube, and the accessory kit. These are 3 separate items that are ordered from AbbVie. And then we have logistics do that for us. It's important to keep a few on hand because patients like to pull out their tubes sometimes, as we found out. Like Devin was saying, we had tried those couple ones from IR and it didn't work out so well. So that's why we like using the AbbVie tube now, because they do have a little bit of a lip on it that will help keep it in place a little better. Also, you might want to consider where to store these, because so they're not used for other procedures, and they are available if the patient needs to come in and have a tube replaced. We had to go through a CRPC review process to get them permanently stocked through logistics. So that's one thing you might have to do. For the female adapters and the male lower lock syringes, I found out just today actually that they can be ordered directly from AbbVie. They don't have a form for it yet, but that's new information. But we were finding our female-to-female adapters on our own. There's a picture of one there. They were a little difficult to find, but I think also that ordering form for the VA does have another resource or 2 on there to find those. The male lower lock syringes, those are just ordered from the pharmacy and sent to the patient. They can order those in CPRS. And we're using, even though the flush has to be 20 mLs, we like to use the 10 mLs. Like, we find it's a lot easier for patients, for the dexterity and strength in their hands to flush, use a smaller syringe for that. And one last thing is the order. You want to make sure there's an order in CPRS and VISTA once the med is started. And that's for a couple of reasons. That's just for, cost capture on the refills, and also just to make sure the medical record is complete. You may need to get it added to the local drug file. And keep in mind with this drug, it comes in 28-day supply, not normal 30-day supplies. So these are some of the challenges and special experiences we have had with this drug. And I'm not saying this to really discourage the use of this medication, because it's a very valuable option for patients who don't have many options left. But there are things that can happen that you should be aware of. At our VA here, we've only had 3 patients on it so far, and we've had all these things kind of happen. So these are scenarios to prepare for in advance. And Devin, please speak up or add anything here, because she's been through all this with me.
A couple tears have been shed, but it's worth it. It's worth it. It's worth it.
Absolutely.
And we'll get to a case study later that will address that.
So the first thing is using stock PEG tubes from the VA versus using the AbbVie tube. We've talked about that already, that the tubes from IR are a lot easier for them to pull out. So we've kind of solved that problem now by switching to the AbbVie tube. We have a patient that pulled his PEG tube out, and he lives hours away. So then he ends up in a local ER in a middle of nowhere Colorado town, and they have no idea what to do with it or anything about it. They don't even know what Duopa is. So that's just one thing to be prepared for. You might get phone calls. We had a pump that supposedly shocked a patient. I'm not Yeah.
Yeah, it's hard to know if it truly shocked him, but it still was what he reported. And you're a lot of your patients with Parkinson's disease probably are tinkerers, so to speak.
Mm-hmm.
They like to tinker. And he technically speaking, it is about a 12-volt battery could have shocked him. But yeah, so that was something that we had to come up. And again, the procedure for replacing that pump had to be addressed.
Yeah, so then we had the pump delivered, then the new pump delivered to the VA. It was lost for several days here because of, where it was addressed to, and it wasn't clear, and anyhow, that was another we had a patient admitted who didn't bring his supply of Duopa with him, and he lives hours away, so we had to try to get that situated and have an emergency supply of Duopa delivered to our VA. And then after that, it was delivered for his next refill. Then it was delivered to the VA instead of back to his home. So then we had to figure out how to get it back to him hours away. Anytime a patient's admitted to a non-VA facility that's going to present a problem, a lot of the issues are the ER, the hospital providers. They're not communicating with the VA provider here about what's going on, and a lot of times, a lot of these folks aren't familiar with Duopa. And even when these patients are admitted to a VA facility, the provider or the pharmacist is really going to have to be involved in helping to explain it to the physicians taking care of the patient, also to the nurses, how to work the pump, how it all works. There's going to be some work involved there. So we had a patient who he enjoys taking his IR, carbidopa-levodopa, while on Duopa. He kind of likes that dopamine high. So Devin caught that and hopefully put an end to that.
Yeah, I had to call him out on whether or not he was being honest about how much oral medication he took that morning, because he wasn't supposed to be taking anything. But he had so many dyskinesias, it wasn't adding up for what his dose was. So
we have a patient who likes to travel for long periods of time to other states, and because you're going to have to make the VA in that location aware that patient is there in case something happens. And also ensure that drug is delivered to them at that location, and then back here when they're back home. I can't. Patient with a broken adapter. We had some difficulty finding them at the time, but I think that's been ironed out a little easier. So make sure you give patients a little handful of them and to take home with them in case.
Right, because that female-to-female adapter, and again, I think this is hopefully a moot point from here on out. But if they don't have that female-to-female adapter, they're not able to flush. And we were not aware of this, that this was not supplied. So this was actually a really huge issue that came up. So, but like I said, hopefully it's resolved now.
You can get them from AbbVie now too, so. I can't stress enough that ordering and monitoring Duopa is a time-consuming process, and providers need to be willing to put in the time and effort to do it properly. They need to work collaboratively with pharmacy, prosthetics, the local rep, GI surgery, and so on. And I have to say Devin's been like a model example of this, but because it does require a lot of time and work on a provider's part. So we've had a couple communication problems with Duo Connect. Devin could probably explain that more, but
yeah. Long story short, and hopefully this will be ironed out as well, but for instance, I had a patient who was complaining that their tube was not able to be flushed. They reported it to the Duo Connect nurse. However, the Duo Connect nurse did not report that to myself, nor I'm not sure where it got reported. So there's no communication currently between the nurse that goes out to assess the patient for follow-up visits and the provider. So that has been certainly addressed, and hopefully we'll get some. Yeah.
So we've had a couple procurement issues with the Credo as well, and we've hopefully ironed most of these out. Like treating the VA like an insurance company, asking for prior authorizations, billing for wrong amounts, things like that. So like I said, these have been addressed, and we're working those out. And then one last thing, make sure the patient prior to surgery. There's only one in the kit. So, all right, I'm going to pass it on back to Devin for some patient perspectives.
Great. So I actually have one patient that felt extremely limited with his choice of garments to actually carry the device. So long story short, he wound up watching Shark Tank several months ago, and he actually contacted the Scotty Vest people about modifying a vest to actually carry the Duopa pump. This is one of the vests that they recommended. It's called an RFID travel vest, and it actually fits really snugly. It zips up to secure the pump. It doesn't have that brick-shaped bulge under the vest that you typically see with the other vest options that are currently out there. Recommendations have been like cargo pockets of shorts. We have one patient who loves his cargo pockets, and that's how he carries his pump. And the other patient loves his fly fishing vest. So there's other options. So I'm going to go through this super quick. Long story short, subjective 67-year-old male with Parkinson's diagnosed at age 43. Status post bilateral STN DBS implantation in 2005. And he'll look like your typical Parkinson's disease patient. Dysarthria, dysphagia, poor balance, occasional pseudobulbar effect. So he presents to follow up, and here are his list of meds. His physical exam is going to look basically like your typical Parkinson's disease with advanced disease. So assessment is here. You can read that. So basically, he was the ideal candidate for Duopa therapy. So we're not going to, add on a rotigotine patch. We're not going to increase his carbidopa-levodopa, but we are going to refer him to speak with a peer mentor regarding Duopa therapy. So the outcome was actually the first 6 months of therapy. He went fly fishing twice. He always said that he wanted to eat a cheeseburger by himself, and he was able to do that, didn't have any issues swallowing with it. He had increased function, increased independence, increased his overall quality of life. He had decreased off times, decreased motor fluctuations, and decreased pill burden. This patient happened to be at a skilled nursing facility, and the quality of life was better for both the nursing staff and the patient as well.
Okay, here are our references. And here's this information again on how to receive credit. This one here is for pharmacists. And non-pharmacists, email Christopher Beggar. And we have questions. Time for questions or anything? I think Chris has to unmute the...
If everybody would stand by for a second, I will go ahead and unmute the microphones. Please refrain from hanging up the call as it makes a chime that disturbs the others. So if you can just wait to hang up until this presentation is done, that would be greatly appreciated. The microphones are unmuted. Feel free to ask questions.
No questions? Anybody?
Hi. Hello.
Hello.
Yes, this is Ramon Rodriguez calling from the Orlando VA. How are you doing? How are you doing?
Good.
Listen, I just have a quick comment. So I was part of the clinical trial for Duopa. And I have been doing Duopa outside of the VA for quite some time now. And I agree, initially trying to get the patients up and running can be a little bit cumbersome. However, my experience is that once the veterans, or the patients are on Duopa, I see a very sharp decrease in the number of phone calls and complications, and as a physician, when a patient has advanced Parkinson's disease and they're coming for follow-up, you're really struggling about, what's going to be the next step? What am I going to do now? What trick I'm going to pull from the back? And there's a point that we actually run out of ideas. So, my experience is that for those patients where motor fluctuations, not dyskinesias, but motor fluctuations are the main issue, this can be a fantastic treatment. And I actually find myself in the situation where patients stop calling, and I'm the one calling them to find out how they are doing. And the typical response is, "Doctor, like this is it. This is what I was looking for," and they're just very grateful. So, from the perspective of initiating therapy, I know it can be cumbersome. However, once the patient is fully titrated, I think that it is going to pay off.
And thank you for sharing that. And that's very similar to our experience as well, is that even though it is very cumbersome, the results truly do have that enhanced quality of life. And it seems the acuity is very high maybe at first, but then you never hear from them again because they're doing so amazingly well. So thank you for sharing.
Cole from the Loma Linda VA. I have two patients on a Duopa pump, and both of them pulled out the inner tube out of, the inner J extension out of the bigger peg tube. One accidentally by a nurse that washed them, washed the patient, and then one because he fell. And it seemed like that connection is very loose. It seems like you have to twist it tight to.
Can anybody hear us at this point?
I'm sorry?
Oh, so I think we lost you.
Oh, okay. How much did you hear?
Just that you had two patients who pulled out their tubes.
Right. So it's the inner tube part that comes out of the outer peg tube, so the inner J extension. Okay. And both of them pulled out. And we just noticed there is like a little turning thing. If that isn't tight, it pulls out really easily. So I just wanted to mention that because it happened in both of my patients.
You're right, and that can definitely be addressed by whoever, if it's IR or general surgery, who places that. Because you're right, that absolutely needs to be really tight, and that's where that rep, the surgical rep from AbbVie can help guide the surgeons to ensure that that's really tight so it doesn't fall out.
Yeah, and I don't know what the policy would be, what to do after. With one patient, I just fed it back inside. It was maybe 3 inches out, and we were thinking, should we now get an X-ray with contrast, and it worked. So we just turned it back on, and he got good results. So we kind of assumed it's at the right spot, but it's a whole hassle then to have it reinserted. So sometimes maybe just feeding it back in. If it works, it works.
No, and you're right. That has happened to one of my patients, and general surgery was able to keep the G portion in and just place a new J part, and verified it with X-ray and fluoro.
Yeah. And by the way, here GI does the surgery for us. The GI department, they put it in.
That's great. Good.
Yeah, here too. Yeah.
Any other?
If there's not any more questions, we will go ahead and end. Is there one last call? Is there anything else? Any other comments or questions? Okay. No, thank you.